Good afternoon, everyone, or morning or evening, everyone. It is really nice to be here with you today. My name is Wang. I am from Vietnam. I'm the director of SCDI. There's a community, an NGO, it's a local NGO working with the marginalized community in Vietnam. And I have a pleasure of moderating the section today, which we call Start, Stop, Continue, how to better serve the community in the, for the TB in the context of COVID. So let me first invite Yolande to from the front layers to introduce some ground rule, and then allow me to introduce the presenter, our three panelists, a little bit later. Yolande, would you like to start? Thank you.
I think Olan is.
Yolande.
Hello. Yeah. Hello, everyone. Can you hear me?
Yes, very well. Thank
Great.
you.
Sorry for the delay. So the main instruction we have is to do with the interpretation function. As you can see the instructions on the screen, please click on the globe at the bottom of your screen, and from there select if you would like to use the English option or the French option. We have interpretation available in both of those languages. And this will be available throughout the meeting. So once again, please click on the globe option and then select English or French, whichever one you prefer. And now we're going to go back to Oan, and she's going to go over the speakers and the agenda for the meeting.
Thank you, Yolande. I think we have a 9 minutes. Yeah, go ahead, Yolande. Yolande, please go ahead.
Oan, can you repeat that, please?
I thought that you have something else to say. Please finish what you have to say.
No, so we're going to ask all of the speakers, so Madiara, Andrey, and Ashim, to have their videos on throughout the meeting. And for the participants who are in the group, we're going to have the Q&A and function available for you to put questions into. You can see at the bottom the Q&A button, and you can answer any questions that you have for the panelists which come up during their discussions. You can write them there, and then we will be able to respond to them as they come in.
Yeah, thank you very much. So please be reminded that there's an interpretation function if you don't, because Mirada is going to speak in French, so if somebody who wants to the interpretation from French to English, please use the interpretation function. And the Q&A, if you want to comment or ask question, please put it in the Q&A. So we are going to use the Q&A to look for the people who want to comment or to ask question. We have 90 minutes for this section, and I hope that you can focus on opportunity as well as what we can do in the current situation. We all know that COVID has changed the world in a very, very big way, and there's some concern that COVID will set back some of the achievement we have got on TB. In Vietnam, it is estimated that it will push the TB program back for maybe 10 years. We have already less case detected this year because people don't want to go to the hospital, etc. So that is a concern. However, COVID also provide an opportunity, may open some new opportunity for us. So we today we will discuss about, we will listen from our speaker, but also to discuss about what can we do, what can we start, what we can using this in this COVID environment, what can we continue to do and what we should stop be doing in order to for the community to continue to take the lead on TB and comorbidity. I can start with a small example very quickly from Vietnam. So during the COVID, my organization distribute food for the people who live on the street, the homeless, and the slum people, the slum dweller. So through that activity, in fact, we interact with the population that we didn't interact before. With them, we have in fact refer a number of cases, including the MDR-TB and XDR-TB to the TB program. So it is just an example of a new opportunity for us in this COVID time. We want this section to be open, to be interactive, and to be engaging as much as possible. I hope that everybody will have an opportunity to listen and to reflect, and at the end of the section, people will feel like they gain something, they learn something from the section, or being inspired, or being listened to. So we have 3 speakers, and each speaker will have 10 minutes to speak. We have asked the speaker not to use PowerPoint presentation, but really to speak from their experience, because the 3 speakers we have today are the top people on the community program, and also on the TB and HIV program. So we will invite them to speak for 10 minutes, and then after they speak, we will have 10 minutes for discussion and question answer after 10 minutes. So after 10 minutes, I will stop and move to the next speaker. I also want to use this opportunity to draw your attention to the technical open access workshop on the same topic, which will discuss the in detail different model of work. So today we share the idea, we share the experience, we brainstorm, and then there'll be a workshop that focusing on the model, more the technical, what is called accelerating progress to end tuberculosis, integration between tuberculosis, HIV, and other services. The registration link could be found on the Frontline S Twitter account at Frontline S. The workshop will be conducted in English with possible interpretation to French, Russian, and Portuguese based on the needs of the registered participants. So I do encourage people who speak one of those languages to register, and the registration open by 23rd of October. So with that, let's now move to our first speaker. So it's my pleasure to introduce Ashim Chola. Ashim Chola is a big friend of mine, somebody I admire greatly. He's the Chief Executive Officer of HIV/AIDS Alliance in India. And before joining Alliance India, he was working with Libra, another big NGOs in India. So Ashim will reflect on the opportunities to apply lessons learned from HIV response to COVID-19 outbreak, particularly from a community perspective. He will also discuss the impact of COVID-19 on key and most marginalized populations, such as the drug user and transgender community. Over to you, Ashim.
Thank you very much, Juan, and greetings from India to everyone listening in, watching me. It's a pleasure to be here and to be part of the Frontline AIDS partnership, which we represent. I want to start by drawing our attention to the fact that rather sadly yesterday, the WHO released the global TB report, which notes, no surprises here, that India has the largest burden of tuberculosis in the world. And we know that approximately 30% of India's population has been infected with COVID-19. I know that sounds scary, but it's true. And we also have the third largest population of people living with HIV. So one pandemic and two epidemics, we're dealing with a lot here, and it's a very complex situation. But first, I want to just discuss very quickly what the damage has been, the collateral damage of COVID-19 on tuberculosis. First of all, in terms of the economic determinants of tuberculosis. So you should know that within the country, in India, 140 million jobs have been lost due to COVID-19 and the consequent lockdown. So as a result of this, pretty obviously, a lot of people are poorer. They have poor health-seeking behavior. They've had to walk thousands and thousands of kilometers back to their homes because they lost their jobs. They didn't have money to pay rent and buy food. So the economic determinants of tuberculosis are aggravated beyond imagination due to the COVID-19 situation. The second point that I want to make is about the impact on TB services. So right from diagnostics to TB care to dispensation of medicine and distribution of medicine, there has been a huge impact. And just to give you a sense of how big the impact is, the notifications of tuberculosis, because in India TB is a notifiable disease, the notifications have fallen drastically by 80%. Now, it is not to say that 80% fewer people have been infected with tuberculosis, but because of the problems in the service provision side, 80% fewer cases have been notified. And this is very scary because it also means increased transmission risk, phenomenally increased transmission risk. Mathematical modeling suggesting that for every lockdown month, beyond Ukraine and Kenya, which also have huge TB burdens, India will see about 235,000 new cases of tuberculosis, in excess of what it would have seen for every lockdown month, and about 71,000 excess deaths. So we're talking about a huge impact of COVID-19 again, in terms of transmission, in terms of deaths, in terms of increase of MDR cases. We are seeing that possibly there are going to be about 12,000 in excess cases of MDR tuberculosis. And of course, the vulnerability to COVID-19 infection increases for people with tuberculosis because they live in poor settings and they are not able to maintain social distance. So the co-infection aspect shouldn't be missed out. Now, the impact on vulnerable communities and marginalized groups that Alliance India and the Frontline AIDS partnership works on has been huge. I mean, for example, with transgender persons, the loss of all forms of livelihood, impacting obviously on health-seeking behavior, the aggravated stigma and discrimination that we know that transgender people face in any case, and their exploitative social structures, all of that means that they are far more vulnerable to tuberculosis than they were in the past. And again, the big impact on drug users, people who exercise their agency to make choices that we should not be judgmental about. The dominance of police in the whole gamut of trying to control the transmission means that the police has come far closer to the community than it was. And this basically means that a lot of people are going into jail for petty crimes, and several of them are drug users. And we have another aspect which needs to be considered, the female sex partners of drug users and intimate partner violence, which has gone up because of the lockdown situation and the lack of availability of proper drugs, which also makes people extremely vulnerable. So, as a person who represents an organization that works on HIV and AIDS and has worked on HIV and AIDS for 20 years, we've seen, as Juan said in the beginning, a number of opportunities to inform people who are trying to deal with the collateral damage of COVID-19 on tuberculosis and other diseases, to say that, hey, there are opportunities to apply lessons from our rich HIV response on the COVID-19 response. And here is a sampler. So we have, for example, community-led approaches. So very important that we must ensure that communities are at the heart of all programming insofar as COVID-19 is concerned. COVID-19 survivors must be at the heart of everything that we do. We must scale up community testing. And this has worked extremely well, bringing testing closer to communities. It has worked extremely well for us in HIV, and it will pay dividends in COVID-19 as well. Contact tracing, I don't need to emphasize this more, because you know that from tuberculosis to HIV, contact tracing has been hugely impactful in terms of controlling transmission, addressing stigma and discrimination. And lastly, I would say responsible medication, because there's a lot of misinformation. This is an infodemic as much as a pandemic, and there's a lot of quackery that is going on, and we must have responsible medication. So we put all of these lessons together. There is also an opportunity to use the current HIV infrastructure to respond to the COVID-19 situation. And that is something that Alliance India is planning to implement along with the Frontline AIDS Partnership in India. Thank you very much. Thank you, Juan, and over to you.
Yeah. Thank you, Ashim. And I like the draw of the bike at your back. Is it the draw of the bike at your back? Ashim?
What? Sorry, what was that?
At your back, in your background, I see a drawing of a bike.
Oh, the motorcycle. Oh, yeah. That's my friend's design. That's my friend's design. I'm also a long-distance motorcyclist. Yes.
It's beautiful. Yeah, I know that you are a motorcyclist, and it's really wonderful. Yeah, so thank you so much, Ashim, and it's really enlightening to hear from you. There's a lot of huge problem, increase the number, and I can imagine that if TB is increased in India, we will have a huge increase in the world, because you have such a big population. So in terms of number of cases, you mentioned 150 million people lost a job, 235,000 additional cases for every month of lockdown. Oh my God, it's really, we are very, very worried. But also, enlightening to hear from you about some of the HIV approach, some of the HIV lessons that we can learn from HIV. So you mentioned at the end of your presentation that Alliance India is going to partner with Frontline AIDS to implement some community-based activity. Would you like to share with us a little bit about it? What are the ideas?
Yes, certainly. I can only share with you what has been discussed until now within the Frontline AIDS Partnership, which is that that we want to push ahead with being one of the first community-based organizations that delivers a community response to the COVID-19 situation in India using the HIV infrastructure that already exists. And in that, I mean, very simply, to give you an example, behavior change communication and counseling. Today in India, if someone is is asked to wear a mask, or is asked to, practice hand hygiene, or maintain social distance or physical distance, the person doesn't actually know why. So it can be as simple as the counselor in an HIV program ensuring that the general population is also aware of the reasons why. So there is this whole business of trying to ensure that the same infrastructure is used. What we are trying to do at the moment, one, is to establish a proof of concept project. We want to establish a proof of concept project using research methodology that will show the country, the government, people at large that there is a way to deal with COVID-19 which is different from the current law and order kind of response. And that's what we are trying to do here. Thank you.
Thank you, Ashim. And I see that we still have a few minutes for to interact with Ashim. If anybody like to ask Ashim any question, yeah, I see Jaya Lasmi. Please unmute yourself and speak.
So, Owen, the participants can't unmute themselves, but if they either write the question in the Q&A function or if they raise their hands, they can be unmuted by myself.
Okay, so there's a person raise a hand. Can you unmute them? Yeah. Okay, so the question here is why are there no behavioral scientists in the COVID response as yes? I think it's more a comment than a question. I
think person can speak now.
Yeah, please go ahead.
This is Jaya. This is Dr. Jaya Sridhar from Chennai. So thank you, Dr. Ashim, for that very wonderful presentation. And I think there's so much to be brought from the HIV experience to COVID. But we're really missing behavioral scientists here. And we've also missed a good number of behavioral scientists in the HIV domain earlier. So why is this the case?
Yeah, absolutely. I mean, I wish I had the answer. I couldn't agree more with you. I think it's because of the fact that behavioral scientists are not seen as scientists at all. Sorry to use this expression, Tom, Dick, and Harry thinks that BCC and IEC and BCC are, common sense things. They don't believe that it's something that is rooted in sociology or psychology. So that's the unfortunate bit about the spectrum of work that we do as behavioral scientists.
Yeah.
Thank you.
Yeah, thank you for the question, comment actually as well. And it's actually that is very important comment. And I hope that some scientists, some people in the science community would hear this. We are a bit too medicalization on the COVID response, right? There's even now people deny about mask, deny social distancing. So that is very sad. I could see in the chat, in the Q&A, there are a few questions. But first one to me, so I will respond to that later on. But the question to there's a point.
And there's also a few questions in the Q&A function if you want to look there.
Yeah, I'm looking at the Q&As, and first of all, congratulations to Alliance India for their wonderful work in India. And you mentioned, Ashim, you mentioned that TB is a notifiable disease in India. How much is the decrease of TB notification coming from the private sector compared to last year? So would you like to answer that question?
Yeah. So the private sector is basically providing about 80 to 85% of all TB care in India. And therefore, when I said that there's an 80% reduction in notifications, I would say that it's about 75% that can be attributed to the private sector. Yeah.
Mm-hmm. So among the decrease, 75% from private sector. So that's really a big decrease. And the other question is that how can the HIV response be replicated in the COVID-19 response? I think, Ashim, you already mentioned some of that in your presentation. Would you like to have another remark on it?
Yeah, I think for the person who's asked this question, it's the best way to achieve value for money. We are working in a situation of very constrained resources, and the the best use we make of our resources, the better it is for us. So we can't have siloed programs all the time. So TB has its own siloed program, and HIV/AIDS has its own siloed program, so on and so forth. And in India, for example, we have about 60 siloed programs dealing with 60 different important diseases. And that can't just carry on. So we are talking about, using the same infrastructure and cross-applying the lessons. Yeah, that's what.
Thank you, Ashim. You raised a very important point, and I think what we are trying to do as being here in the TB conference, many of us working for HIV organization, and we want to break the silo. We don't want to have a TB program, HIV program, Alliance India doing on HIV, doing on TB as a separate program. We want to be able to build the bridge, or to build the synergy between the two programs. And so, so I guess your response to the question is that no, we are not planning to replicate an HIV program for COVID-19, but instead the organization working on HIV and TB will also working on COVID-19 to address the needs of the marginalized and vulnerable population. Is that correct?
That's right.
Yeah, thank you, Ashim. There's a thank you for you as well. And quickly, there's a question for me about, the question is that what kind of organization is this, the one that distributing food? So because I mentioned in my opening remarks that my organization distribute food for the homeless and the people living in slum during the COVID lockdown. So it's my organization is local NGO. And the reason why we did that, because some of our clients who was drug user and sex worker also live in street or in the slum, and then they report to us, they call us and say, we are hungry, we have no food, people pass out on street. So that's why we start a program that distribute food to them. So that's as a local NGOs. That's the answer. Okay, so I think with Ashim presentation, we come, and the question, we have come to a very important, I would say, summary that we don't want to have a separate program. The organization working on TB and HIV have a lot of experience for community testing, community-led approach, contact tracing, etc. And we can participate in the COVID-19 as well. So let's me move to our next speaker. It is Dr. Madiara Coulibaly from the NGO Alliance Côte d'Ivoire. She's the executive director of the organization, and her organization, the NGO Alliance Côte d'Ivoire, is a principal recipient of the community HIV and TB component of the Global Fund in Côte d'Ivoire. And I am notified that Madiara is going to speak in French. So if you don't understand French, you can use translation function. I know that Madiara understands English very well and can speak English well, but yeah, over to you, Madiara. I know that you would be more comfortable in French, so please.
Merci beaucoup, Joanne.
Thank you very much. I am very happy to see you after a couple of months in lockdown. I greet everyone, not just on my own behalf, but on behalf of Côte d'Ivoire, Western Africa, and African. Of course, we've had 1 million of more than 1 million deaths due to COVID-19 in the world. And of course, we can see that in this sanitary or health context, it was now necessary to count with the know-how of the NGOs and also take advantage of their proximity with communities in order to enhance the response, particularly in the most vulnerable areas and communities. And I would like to really salute all our partners that believed in our capacities, the capacities of the civil society in this time. Now, the first question, I would like to say that with the support of our partners, we were able to analyze the situation, to propose some key action and share information. We are part of a regional network, Francophone Africa Against Tuberculosis. And with this network, we benefited from the support of STOP, and we were looking at the needs of TB patients in the context of COVID-19. We were able to participate in a number of webinars that were organized by some of our partners, like Frontline AIDS, Stop TB Partnership, and these webinars were allowed us to share information, to share practices and different possibilities of actions. We have to understand that in the COVID context, it was difficult for some of our organization to intervene on the ground. Elsewhere, some sister organizations were able to mobilize their resources and innovate when it came to the response to COVID-19. In Côte d'Ivoire, with a number of our implementation partners, we came out with a contingency plan against COVID-19, and this plan allowed us to continue with our services towards TB patients, but also those who are infected and affected by HIV. So concretely, we were able to follow them via telephone, whether it was TB patients or HIV. We shared information with them, invited them to come and fetch their drugs, and we did it with the National Program of Fight Against TB. So we had a 1 month program, and also the National Program Against HIV. We had about 3 months of ARVs that we were able to give to the patients so that they will not be in a situation where there's no drugs, because quite a number of patients that were coming from vulnerable areas were not able to go towards the small pharmacies and clinics where they will be able to get their drugs normally. We also had some prefabricated facilities where we would assemble some of these patients and other new cases. We will look at them, and only if they had no COVID-19 symptoms, then we will send them back. And this was done mainly in prisons, just to make sure that there was no spread of the COVID-19. There were also some protective equipment that were given in the to people in conjunction with Ministry of Health. And we were therefore able to understand the situation and to safely provide services to our patient. And we've been able to document all these, and we were able to send some consultant to be able to document everything that was done in the context of COVID-19. Now, for the second question, we have to note that COVID-19 reminded us how stigma and discrimination can be a huge obstacle for patients to have access to some of their care and medication. And of course, we look also at the promotion and protection of the rights of our TB patients. If for HIV things work well in that area, for TB it is only now that we are launching things in a number of programs, but we have quite a number of obstacles and hurdles. But now we have quite a number of programs that have been developed that can help us in our fight against stigma, discrimination, and the violation of rights of our patients. And we want to see how we can have sufficient funding for this type of programs. Of course, we've seen the reaction of some groups of population. We've seen in Côte d'Ivoire some hostile behavior. And this is not just linked to COVID-19. We remember when we had Ebola breakout, we had the same type of response from the communities. So it is imperative that we ensure that people are able to be educated on how they can react towards this type of breakouts and pandemic. We have to be able to activate some type of framework where people will be able to interact. We understand also that it was important to work differently in using digital platforms, and that will help us in this time of very limited resources to still be able to work and interact together. If we were talking football here, we would have said which are the actions that should get a red card. I will give only one red card, and that to see stop to making the response against COVID-19 something that is too vertical, and they were not able to involve different programs of the fight against TB, because some of the response of the two diseases are similar, and we see that for HIV and AIDS, for example, again, a number of programs were not involved. And though quite a number of resources were given, they were not really able to benefit the response of TB and HIV. And we've not seen really a change of behavior in the population. And we've seen that after a number of intensive campaign on COVID-19, we see that people are relaxing and they are no longer strictly using the different protocols that have been given, like the wearing of masks and the social distancing. And but I would like to maybe end here for now. Thank you very much.
Thank you very much, Mediara. And it's really nice to see you. I haven't seen you for so long. It's lovely to see you. And thank you for sharing experience from Cote d'Ivoire. You've done so much during last few months. When I listen to you, it's like, oh God. But it's really, and I see that Andrey is listening very carefully on what you said as well. You are principal recipient of both TB and HIV, and you are wondering how you can have enough funding to also respond to COVID, to address the need of the population that you are serving, but also addressing the emerging needs due to the COVID. But you have done some fantastic job to get people 3 months of ARV, etc. And some of the point that you mentioned about the hostile behavior during the Ebola and during the COVID, I think that's very interesting and important to look at as well. And I am so pleased to listen to your red card. In fact, it's almost like a concluding remarks with what Ashim mentioned earlier. Stop to make it vertical. We don't want to make vertical COVID-19 response. Right? It had to be integrated. It needs to build synergy. The floor is open for question. If people have a question for Mediara, you can put in the Q&A. Yeah.
Oh, and just before we go into the questions, can I ask the French interpreters? I'm not hearing the French interpretation for Owen at the moment. Can we please start the English to French interpretation again? Thank you very much.
Thank you. I hope it works now. Is it okay, Yolan? For the
yeah,
French?
Owen, that's great. You can keep going now. Thanks.
Okay. Okay. So I see from the chat that we have people coming from Turkey, from Indonesia, and I know that there are people from India, from different part of the world. So it's great to see the participant of this section coming from all over. And it would be nice if you if the participant can just say hello and tell where you come from, chat, so that we know where we are in the community, because we can't just turn to our left and our right to say hello, I'm here and here from this and this country. So it would be nice to use the chat for that. I see a question for Ashim, but yeah, greeting from the Philippine Christian. So greeting Christian, and yeah, very nice to see you. Wonderful. Myanmar, India. Yeah. So there's a question, and I would like to bring that to Miriara. Do you think we can still meet the target of TB elimination despite the COVID-19 lockdown? So for Cote d'Ivoire, what is the target for TB elimination? Is it 2025 or 2030? What is the target for your country? Midiara? When you win NTB in Cote d'Ivoire before COVID-19?
Alors, je pense qu'avec des
I think with the efforts and the contribution of all the sectors. When I speak about all the sectors, I mention the civil society, the public sector, but the private sector as well. If we mobilize ourselves, even if in 2015 the objective is not achieved, we could still vote for chances to get closer to the elimination. And the question is how we seize every opportunity that presents and transform this opportunity in action, be it in emergency health. We have to mobilize the entire actors to be able to act with the population to use proper methods to fight against TB. And when we look at actions in the private sector, we have to ensure that companies and responsible of companies have put in place proper methods to protect their workers and to avoid contamination of TB in the companies, and those who are sick have to be treated, and their rights have to be respected and applied, which means they have to be 100% guaranteed that they're not losing their jobs, which could lead them to hiding their sickness.
Yeah. Thank you, Medira. We need to work on together. And it's when we are talking about TB response, it should not only about X-ray and gene expert and the medication. It's about securing the job, addressing stigma and discrimination, etc. But Ashim mentioned that there's a huge increase of TB in India during the lockdown. Do you have the similar situation in Cote d'Ivoire? Do you have more TB during lockdown? Or do you have a data on that? Or what is your observation?
Alors, ce qui s'est passé en Côte d'Ivoire, c'est que pendant la pandémie,
What happened in Ivory Coast is that during COVID, there was a reduction of visits to health institutions, and people were very scared. The population was scared, which led to an increase in death. We also had a decrease in notification because the patients were afraid to be identified as COVID-19 patients. So they preferred staying home. And because there were restrictions of movements during this period, there was a reduction of notification, augmentation of death. Quickly with the prevention plan, which had to do with the national program, the measures that were taken had helped us to fight back and to have an aggressive action for the patient, to look for the new patient, to encourage the patient to come forward. We encouraged them to come and take their medication because the public transport had become an issue. We had to reduce the number of passengers. Brief, we took a number of actions to encourage the patient to come. We called them, we assured them that they have to come back to health institutions to take their medication and continue their treatment. COVID-19, we have to admit, has created a reduction for a certain time on all the indicators. but the riposte plan put in place helped us to fight back.
Thank you, Mariara. That's a great insight, and I think that on TB, when the number of notifications go down, we should start to be worried. In this context, it's not because we have less TB, it's because people don't come, and then, as you said, the notification go down, the death go up. I could see the comment from Blessy Kumar. Good afternoon, Blessy. Lovely to see your comment. Blessy is a long-term warrior, long-term fighter for TB patient and for the community. So I think everybody in the TB community would know Blessy. And Blessy have a comment on the chat box. The reality is that we was lacking behind in achieving our TB target even before the COVID pandemic. And now it is even worse. I cannot pretend to be Blessy. Blessy would be much stronger than this. But what this means is that we need to multiply our effort by 10 times and accelerate. Absolutely no time to leave. Life depends on it. 100% agree with you, Blessy. I think it's probably not only 10 times, but we need to try many more times the effort, and agree with Blessy. We've been in India, in Asia, we've been with Midiara in Cote d'Ivoire, in Africa, and now we moved to Europe. It's my pleasure to introduce Andrey Kleppeco, a person that I don't think I need to introduce him very much, but anyway, that's my job. And I hope there's some new participants, new in this area and don't know Andrey. That would be really nice as well. So Andrey is Executive Director of the Alliance for Public Health. The people who work on HIV for many years probably heard about International HIV Alliance in Ukraine years ago, and this is one of the largest HIV and TB focused NGO in Ukraine and in Eastern Europe. So Andrey is managing one of the largest harm reduction program globally providing services to over 200,000 people who inject drugs. The Alliance of Public Health in Ukraine also doing scaling up on opioid substitution therapy program. Is the largest program in Eastern Europe and Central Asia, and run a growing TB program in Ukraine, focusing on procuring and providing access to up-to-date diagnosis and NDR TB treatment. Andrey is also a leader advocate in access to hepatitis C treatment. So Andrey is many things. But one thing that also very important that he's here is that he's a member of the developing country NGO delegation to the Global Fund Board. So he is a policy maker, decision maker at the Global Fund. So it's great that Andrey is here, not only for the NGO that he's leading, but also for the Global Fund. So Andrey, over to you.
Thank you, Anne. It's really a pleasure to see you all and to participate in such a great and important event. So, yeah, I have different roles, but maybe firstly we'll start focusing on our work in Ukraine. Of course, COVID came as a surprise for many. We all were not prepared to this, and some emerging things were driven some resources and commodities from ongoing programs. Like I remember when COVID started, we got a request for respirators procured for TB program, actually, to be well, not given but borrowed for immediate need related to COVID. So this is an example that TB program in many situations became a resource to address emergencies. We are implementing quite a significant scope on the ground in Ukraine. My organization, Alliance for Public Health, well, involved at least in 5 activities. It's active TB case finding among most at-risk populations, people who use drugs, sex workers, also homeless people, Roma people, other key risk groups. So another area is TB contact tracing. Another one is medical and psychosocial support for TB and especially drug-resistant TB patients. It's also advocacy and policy work at the national and regional level. And we are involved in also multi-stakeholder mechanisms such as Stop TB Partnership Ukraine or a parliamentary platform on TB, which unites quite significant number of parliaments. So when COVID started and lockdown started, many things resonates. What was done in Ukraine by us, by our partners, resonate to what Ashim and Madiara also described earlier. So, of course, lockdown and quarantine cut off many people from accessing to services, first of all, medical services. And in this situation, NGOs, community-based organizations, civil society organizations became actually the real linkage and real contact between key populations and healthcare providers. They couldn't access medical services, but at least they had contact with NGOs. And NGOs actually helped to renew this access, because one of the barriers was requirement to have COVID tests prior to accessing medical facility. And it was paid tests, but people from risk groups, they couldn't afford paying for the tests. So those patients who needed TB services, medical services, NGOs actually provided some funds for tests and provided support to make sure that they are accessing services. So we allow to make reprogramming in order to do this. Another thing is pathway to services became 5 days longer. So it was critical not to lose contact with people. Because, as I said, with the additional requirement for tests, but also for extra visit with a family doctor at healthcare facility. So it's another thing to mention, that the workload on civil society organizations, workers increased actually due to this situation. And for healthcare providing TB services, we observed even some decrease in the work in this area. In other areas, yeah, they might got more time spent in on COVID-related issues, but for TB activities, it's reduced. Great, and we already talked about some innovations, and of course, we all found out what works best in the distant modality. So DOT, which used to be directly observed treatment, actually became VOT, video or virtually observed treatment. And again, role in this VOT was shifted rather from medical professionals to civil society, supporters, yeah, or even medical staff, but hired by civil society. So, and it led to the great results. In Ukraine, we did analysis of the same period, first half of 2022 in comparison with the same period of the last year. And due to this ability to shift patient support to video observed treatment, we actually didn't observe any reduction in the treatment adherence. It was kept at the same level, which is great result. And civil society partners really played a critical role in sustaining these results. We already heard that in many areas in TB response, we didn't froze, but we actually sliding back. But due to this civil society engagement, we managed to keep the same level of engagement, not to reduce in terms of the treatment adherence. Another thing during the quarantine, in some months, public transport was closed or access was limited. So in this situation, also civil society partners allowed to organize transportation for TB patients and those who need diagnostics there to go to hospitals with additional transportations. A big barrier for linkages with the risk groups was strict quarantine measures, which actually didn't allow to continue work in the same modality, which is called outreach. Outreach, working on the street, not waiting for the people to come, but rather proactively searching for people, offering them help, responding to their needs. That's what we used to do for years. And with COVID-19 restrictions, we couldn't continue work on the streets at the same scale as we used to do. And in this area, unfortunately, we see the negative impact in TB detection rate among most at-risk populations. The same period, first half year of 2020, in comparison with the last year, we observed a drop in TB detection rate by 37%. But for drug-resistant TB patients, decrease is not so dramatic, but still there is a decrease. It's a decrease by 9% in 2020 in comparison with the same period of 2019. So we are suffering from consequences of COVID. So definitely there are evidences of negative implications on the programs on the ground. There are also risks, additional risks to the country activities, in particularly delay in procurement of TB drugs. This is very, very worrying signal, and we are making with all the partners not only noise and advocacy efforts in bringing this to policymakers and actually resolving the situation, but also offering some ad hoc support. Some of the medicines we were able to also provide additionally, not to allow treatment interruption from our resources. So this is another area where civil society stepped in as a solution offering mechanism. And another big important thing that from the patient's perspective, role of psychosocial support substantially increased and demand for this. Because in the lockdown, some patients faced not only a wide range of the problems existed before, but additionally faced some mental health related issues linked to the lockdown, stigma and discrimination, as it was mentioned, and many other things. Finally, with PPE, we already heard that colleagues mentioned that provision of the PPE, personal protective equipment, is also critical to protect civil society staff, social workers, medical also staff working on the front line. So masks, gloves, sanitizers are critical, and we are happy that from the very beginning, from early March, we actually managed to negotiate with the Global Fund to use savings in order to quickly procure this PPE and quickly provided it to civil society organizations, our all implementing partners on the ground to ensure safety of the staff and team working on the ground. Well, this is briefly. I'm happy also to wear in another hat, to talk about my role with the Global Fund board and some priorities we see for the Global Fund. But I think if any time left, I'm happy to talk on this, or maybe in the form of comments or questions also to be able to elaborate on this.
Andrey, this is great, and I'm so glad you mentioned your hat at the Global Fund, and I will make sure we have time for that. But I could see that there's a lot of interest in your presentation. I know that we can spend all day listening to your experience in Ukraine, which is so rich. But I see in the Q&A, there are already 2 questions for you. And I see a few hands raised, but please, if you can type your question or comment either on the chat box or better on the Q&A, that would be very helpful. So there are question about VOT, the video observation therapy. The very interesting question from Busi Siwi Beko, the DRTB counselor from MSF in South Africa. So the question for you, Andrey, with VOT, did you experience any challenge related to patients that don't have a cell phone? If people don't have a cell phone, and if people don't have a cell phone that have a camera. And secondly, how did you deal with stigma, as some of the patients will not feel comfortable to do video? So let's start with this question, Andrey.
Yeah, this is an excellent question. Of course, all humans are different, and some of them, as we all, some of them, even today, yeah, some of them put in video on, some are not. So with VOT, it's even more challenging because really it linked to stigma and pressure and kind of control, yeah, feeling of being controlled. I would say that for patients who started with DOT and continue with VOT, there are not so much problems because they used to even
to take medication in front of other people.
Exactly, yeah. So for them, it was a kind of relief, yeah, that they don't need to come to the medical facility, and it was good. In terms of the new patients, it's of course a challenge, and it was a challenge, and it is a challenge. The thing is that social workers and medical staff, but hired by civil society, are engaged in this. And I would say that there is a lot of friendliness and kind of even peer attitude from civil society to patients. So in this case, these barriers were not so significantly, I would say. For some patients, we use even not, yeah, for those who used to have, well, nearly everyone has a cell phone, but not everyone has a smartphone. So for, with some patients, we also use different mechanisms, not only kind of different channels, like there are a number of Skype, WhatsApp, Viber, Messenger, yeah. So I think we allowed some flexibility depending on the people's need. But also we provided patients with, we didn't provide cell phones, maybe only in exceptional cases, but which I don't have data now with me. But we provided some data, some payment for internet for those who require this.
Mm-hmm. So you pay for the data, you pay for the phone. I mean, you give them money for the phone so they can get connected on the internet. That's great. But do you, just for my curiosity, because when we discussed about that in Vietnam, there's also a concern, only a concern that people who use drugs don't have a cell phone. And if they have one, they may not be able to keep that for a very long time. I mean, not everyone, but on a few. So do you go into that situation and what you do about that?
Yeah, that's true that some of the, yeah, like if we talk about homeless people or some people actively using drugs, so they, well, usually they have the phone, but not necessarily the same number, as you said. So because a lot of drugs, well, drug search and procuring drugs are happening through the mobile phone. But as I said, not necessarily the same number. So it's important not to rely only on one channel or on being kind of connected only by cell phone. So that's why we still kind of, for the most, I would say, well, not difficult patients, but patients with additional needs and additional risks, we need to think what is a backup plan with some outreach or connecting through friends or partners.
Yeah, and that is a case by case, right?
Yeah.
Thank you, Andrey. And the other question for you from Dr. Meratu from Ethiopia, working as a regional coordinator for Elimination TB, ETBE project implemented by MSF. So during the lockdown time, how were you able to give medication to the patients in their home? Who was monitoring the VOT? How did the civil society participated to replace the medical staff as a treatment supporter? Did you train them? So not only one, but several questions, but I guess you got all of them already. So go ahead, Andrey.
Yeah, absolutely. Thank you. Thank you for the great questions. Yes, firstly, I would like to ensure that all staff involved in psychosocial support and VOT was trained initially. So most of them were trained before, even for DOT, but we also continue trainings virtually. So with COVID, we did a lot of virtual trainings as well, using the same modality as we use now, Zooms or Skype training. So that's absolutely correct. And in terms of the medication delivery, so well, in some usually again it's done through support of civil society, providing medical support and having still contacts with the patients from time to time. From HIV experience, we know that some of the medicines are sent by post, by mail. It's not fully regulated legally, but in reality, we need to find a solution for this. And from HIV experience, I would say that it was successfully done. Also, we use confidential mail, so it's not delivered that everyone knows who is getting what. So it's only a number, so you can receive this parcel using this number and present in your document, not necessarily in your building. So it's very good. It's very good solution.
Mm-hmm. So it's not like hand delivery by your staff or by the CBO, but you use the mail, the postal delivery, right? So this is very smart actually, and I think that there are two area of business that develop very quickly during the COVID is the delivery services and online digital services, and you are using that. Mediara also mentioned in her presentation about the need of using digital technology, and Ashim also mentioned that, and here you are working on that, using that. And I see a hand raised from Megan for some time now. So Yolanda, if you can help to unmute Megan, and Megan, your question please, or comment. Go ahead, Megan.
Yeah, so I've asked Megan to unmute now, so her camera or her microphone should be working.
Yeah, thank you.
Okay, it's possible there might be a delay on Megan's side. Maybe we can move on to the next question and come back to Megan. Okay,
so let's go to the next question before Megan can come live. So there's a question from August. would you explain more clearly about the barriers of TB detection recently? You mentioned the reduction of 37% of detection rate. So what are the barrier, Andrey?
Yeah. Firstly, maybe I also would like to clarify. So we didn't completely shift it to the delivery of drugs by mail, but that's exceptional rather for those who are in remote areas. So those who are at the same city, we use our partners like Red Cross, for example, for this. In regard to the barriers, as I mentioned, the biggest barrier was that shifting from outreach work to more like virtual work. Or, for example, we used to do screening among people who use drugs. But now when we are not in direct contact, that's the main explanation why it's happening. But slowly it's improving because this period covers the first months of lockdowns where quarantine measures were stricter than usual, etc. So I think, yeah, that explains the reason. And another reason, stigma and discrimination, because some of the symptoms are similar to COVID. So even those who previously were coming by themselves and sharing their symptoms now afraid to disclose this. So it's a stigma associated with COVID. So I would put it in this way.
Thank you, Andrey. That's excellent. So two important barriers, stigma and the fact that we cannot see people face to face. Now, I hope that Megan is audible now. Megan, your question or comment?
So I've asked Megan to unmute. It's possible she's not available at the moment, so we may have to move on to another question.
Okay, so we will process with another question before we turn to Andrey, the member of the chair of the board of the Global Fund. There are two questions, and I will put it into one, and Andrey can answer one time. So VOT is seen as a helpful digital tool during this pandemic. Was there an increase in the number of patients who prefer using VOT in your country? If yes, is there support from the government? And then the other question also about the VOT, who pay for internet during the VOT? Yeah, over to you, Andrey. VOT, a lot of VOT question.
Yeah, I think, yeah, thank you. It's great that VOT raised so many questions. So we are we are quite responsive to the patient's needs. Yeah, we don't provide kind of standard package for everyone. And someone who has the data, internet data, already and didn't ask for this, so it's not obligatory that we will pay for this. But someone who needs this, we through NGO partners, we NGOs actually paying and providing data or kind of topping up the mobile phone with a card. So it's important to kind of keep this flexibility, not just to have a standard package for everyone. In terms of VOT, is it increased?
Are there people who prefer VOT over DOT?
Now it seems like yes, my feeling that do, yeah, we do this data feedback that more people prefer VOT.
That's interesting, and I mean, not a surprise, but it's very nice to hear. It's great, Andrey, and I know we can go on and on as with other presenter, but we have only a limited time left, and I will give you 3 minutes as the member of the chair of the Global Fund representing developing NGOs. In the board of the Global Fund. So your 3 minutes with the community.
Yeah, thank you. Yeah, I'm a board member on behalf of developing country NGO delegation. So I assume that most of you now are from my constituency. So I'm not ending this conversation, but really considering as a starting point. Just several messages. One is TB is really underfunded. In comparison with HIV and malaria, really funding for TB is substantially lower. So while developing on the new strategy for the Global Fund, our delegation will try to bring more attention and more funding for TB. And this is my position personally as well. Secondly, because of substantial share of the domestic funding for TB, in the case of emergency like COVID, it appeared to be at higher risks than programs funded with international donors. So those countries transitioned and committed to procure medicines by themselves, to provide services through social contracting, now kind of sliding back. So this is another risk area we need to really keep eye on, not to allow civil society be left without funding and patients left without medicines. Finally, with the Global Fund, we have only 4 strategic priorities. And one of the 4 is human rights and gender equality. It's not one of the 10 or one of the 100. It's really in the core, one of the 4. And for TB, in the time of COVID, it became evident that these are critical things we need to pay more attention. We need to put funding also, because activities can go on if they are funded, not only on voluntary basis. So it's critical to fund human rights, to fund civil society, to fund initiatives on ensuring gender equality and gender-tailored programs.
And Andrey, I hope you will also fight for the integration of COVID response to the HIV, TB, and malaria program. I'm sure you do. We have just a few minutes left, but I would like now to invite on the our 3 brilliant speakers to give a 1 minute of reflection. We have a very interesting conversation and we learned so much from 3 of you. By that order, Ashim, Miriara, and Andrey, what is your reflection of today's section? What is your inspiration or enlightenment, or what you find the most interesting things today? Ashim, over to you.
Thank you. So I found today's session very interesting from several perspectives, but I'll focus on just one, and that is that there is a sense of desperation. So I'm not feeling extremely positive because I'm seeing that, you know, systems are breaking down. We're still clinging on to some silver lining in the cloud, but frankly, it's not a pleasant situation at all. And let's not fool ourselves into believing that there's something miraculous is going to come around the corner, irrespective of whether we have more funding. Frankly speaking, the one thing that I would like to mention, which seems to have come through in some of the questions as well, that this is not the time for populism, and this is not the time for nationalism. So once we talk about, stop being vertical and, integrate, we also need to have cross-country collaboration and in-country understanding of the fact that whether you are in the opposition or you are a ruling party or what, every country in the world today that I know of that has been speaking openly about the COVID-19 situation or the TB situation has been bordering on populism and nationalism, trying to say we are the best, we are the best, we are the best. And in that process, they are refusing to accept reality. And to me, that is the most dangerous part of the trajectory that we're headed in. Thank you.
Thank you, Ashim. And I can just echo what you said. No country is safe unless every country is safe. Nobody is safe until everybody is safe. I can speak from the experience of Vietnam. We have a very few cases of COVID. We have a very few cases of death, but we are, in a way that we are locked down inside the country. We can't travel. We are afraid of welcoming people to our country. We can travel within the country, but that's it. So we will not be safe until everybody else is safe. So it's really a global issue, and it's more than ever we need global solidarity. And thank you, Ashim, for reminding us about that. And now we go to Midiara. Midiara, would love to hear from you.
Alors, moi, j'ai été très honorée.
Yes, I was very honored and very happy, not just to see your faces, but also to be able to take part in this session. Three key points. The first is the interest of taking into account issues of stigma, discrimination, and protection of the rights of those who are infected by COVID-19 or TB, and to also create a better preparedness of our community in order to reduce the tension between the service providers and the ownership at the community level. The second point is the integration of the different approaches. Let us not make it too vertical. If we want responses with more impact and sustainable responses, we need to think in terms of collaboration and integration. And third point, of course, is the example of is the use of the digital platform, how we were able to work together, just like Andrey said, how we were able to interact and even innovate in our different approach. Thank you very much to the organizers to give a voice to Africa as well.
But thank you so much. And one thing, and I still want to mention one thing for me, is that community system is into play now. And it's great that with the investment from the Global Fund, we are able to build a community system. And now it's paid off. So thank you so much for all the participants who have stayed with us all the time. Thank you, our wonderful three college. And thank you, Frontliners, for organizing this. Thank you, the union, to giving us the opportunity. And please take care, everyone, and stay well. And I hope to see you in person at some point. Yeah, bye-bye.
Goodbye.